Next with us, we have we have Dr. Genevieve Gabb from South Australia Health, and she's going to talk to us about the guidelines and treatment for hypertension. Yes, Dr. Gabb.
Thank you. Thank you to the early careers researchers for this opportunity to talk about this very broad topic of guidelines and treatments for hypertension. I thought I'd just start by, I thought I'd just start by painting a little background. And there's over 100 years of observational data around blood pressure and hypertension, 50 years of randomised trials, and 40 years of guidelines to underpin our knowledge in relation to this area. So advances in technology in about 1918 led to the possibility for life insurance companies in North America to collect information on both systolic and diastolic pressure and mortality events. And this firmly established the relationship between elevated blood pressure and mortality risk. Evidence for the effectiveness of treatment of hypertension was unequivocally established over 50 years ago with the publication of this first randomised controlled trial. These patients had very substantially elevated blood pressures and with a very high background rate of events and effective risk reduction. There were only 2 people needed to be treated to prevent one event. This was a dramatic result for a condition at that time which could often lead to the feared disease state of malignant hypertension. So 40 years ago, the first guideline on high blood pressure was released, and the purpose of this guideline was to provide some practical recommendations as to who could be expected to benefit from therapy, antihypertensive therapy. And at the time, that was around a diastolic threshold of 105. So with this richness and wealth of data and this history, there are lots of ways to cut the data and analyse it or synthesise it. And so hypertension guidelines have been trying to fill that role for the last 40 years. This is the most recent batch of guidelines, some of them you've already heard referred to, between 2016 and 2020. So some of them are linked to specific geographies, such as the Australian, the US, Canadian and the Japanese, others to broader geographic regions, such as the European guideline, and the most recently released ISH guideline, which Alta discussed earlier, that's intended for global applicability. These vary in size and length and the number of references provided to support them, and links for each of these are provided. Just by way of background, each guideline is developed under the umbrella of a specific organisation, such as an NGO is in Australia with the Heart Foundation, or professional groups such as the ACC or the ESC in US or Europe, or it could be an organisation that's got a broader role in producing health guidelines, such as the NICE guidelines in the UK. In Canada, there's a specific organisation called Hypertension Canada, which is specifically dedicated to hypertension and its control, and this has got a very broad representation. And the ISH, as you know, is an international organisation with a focus around hypertension, and particularly with a research focus. These identify guidelines, the authors of these guidelines supported extensively by lots of reviewers, librarians, evidence review teams and medical writers. So the point is that these are really very large cooperative efforts, and they involve a lot of discussion. And for some of these, such as the NICE guideline, the discussions are available publicly and can be quite informative as to the issues considered. In terms of developing guidelines, open public consultation appears to occur infrequently. It did with the Australian guideline, and the clear identification of involvement of consumers is variable. The formats of these vary somewhat. A lot of relatively simple documents. The NICE guideline, for example, has got as an electronic thing with a structure to it, so the guidelines are listed briefly at the front with then more extensive supporting information underneath it. So some of these guidelines that are well established are well supported with resources for professional education and also patient decision aids. And some of them clearly have a focus on implementation. The Canadian guideline in particular has got a very active evaluation program allowing for a feedback loop. Just to make a comment, which Alta alluded to earlier in terms of the ISH guideline with its essential and optimal targets. So this is acknowledging really the exponential nature of the increasing risk with increasing blood pressure, so the greater imperative to treat at higher levels, together with the practical limitations in low resource settings. Just one thing of note, the Australian guideline was recently noted on that important authority of Twitter to be one of the most coherent blood pressure guidelines, and this came from a leading Canadian blood pressure expert, so it's quite a compliment. Now, just to go over some, not so much the content, but aspects of guidelines to help understand differences. So for all of them, there is an extensive evidence base from both randomised trial evidence and also observational data. Often questions remain unanswered, and so there's reliance on expert opinion to a degree. Some of the guidelines, such as the Canadian and Australian, prioritised evidence that was informative for impacts on cardiovascular outcomes, rather than simply effects on blood pressure. And so this may account for some difference in emphasis between different guidelines. In relation to diagnosis, blood pressure is highly variable, as been discussed earlier, and measurement is challenging. So historically, the basis for diagnosis has been repeated office measures, and that's been the basis for inclusion in many of the trials around therapy. And it remains listed as contributing to the diagnosis in most guidelines. One measure which has been discussed a little is that of automated office blood pressure, and that's the process where several blood pressure readings are taken. It could be a number, say between 3 and 5, after a period of rest in an automated fashion, and then an averaged reading is generated by the machine. Now, these readings are generally lower than clinic blood pressure, and just to note that this is the preferred method of blood pressure and has been used for some time in Canada, and it was also the method used in the SPRINTS study. So there is an increasing emphasis, because of the problems with measurement, across most guidelines for out-of-office measures, as these are more closely aligned to end organ damage and cardiovascular outcomes. So the accepted range for these out-of-office measures, it's important to realise, is lower than for clinic measures. Different places have, so the Japanese, I think, favour home blood pressure, and the Canadians ambulatory measures. The definition of hypertension is similar across many guidelines, around 140 on 90 for clinic pressures, and that reflects the clinical trial evidence for a level of blood pressure where pharmacological therapy is most being demonstrated to provide a benefit for people with uncomplicated hypertension. The US guideline, in contrast, has an altered, slightly lower definition, but it's important to understand that this has been made on a slightly different basis, in that it's made at the level of blood pressure where it's recognised from observational epidemiological studies that the cardiovascular risk is increased, rather than necessarily a level where treatment has been demonstrated to provide benefit. In terms of initial pharmacological therapy, guidelines vary, with some having an emphasis on initial monotherapy, such as the NICE guideline and the Japanese guidelines, others saying either approach is okay, or others strongly favouring initial combination therapy. I'll talk about this a little more in the Australian context later. So as we said, automated office blood pressure is preferred in Canada, and most guidelines make some comment about automated office blood pressure. Most say that the values are lower, but a number of them are somewhat cautious and say it's not the method used in their particular setting. I just thought I'd talk a little bit about risk and how guidelines deal with risk. First, a comment about risk. So the relationship between blood pressure and risk has been of interest, as I said earlier, for over 100 years, from that 1925 blood pressure study. And if we look at what the guidelines say about risk, first we'll consider a few aspects of risk. So large components of risk are determined by age and sex, and these are not modifiable. Another aspect is that if someone is at high risk, they may retain a large amount of that risk even with modification of blood pressure. We need to think about events. How do we count events that occur in younger people compared with older people? The other thing about risk is that because risk is about events, it's really about disease. And so if you're interested in health or optimal function, how does risk relate to that? The other thing that's required for risk estimates is that we have local knowledge of what's happening in our population and current knowledge that can change over time. And the other question with risk is, what's the time horizon that we're interested in? Is it 5 years or 10 years or longer? Now, if you look at the guidelines, they all recommend risk assessments, but they do vary in both how they suggest assessing risk and also as to how they think risk should be considered in terms of decision making. So time horizons may vary from 5 to 10 years, and that could be quite short if making decisions for young people. Some risk calculators consider fatal and non-fatal events, others only fatal events. And some guidelines, while encouraging risk assessment, are in favour of earlier treatment of blood pressure to try and avoid this problem of residual risk and prevent hypertension-mediated organ damage. And the Canadians in particular advise against using risk to support treatment decisions because of concerns about the relevance of their risk calculators. So this is just an example of a patient that I came across a few years ago who had developed an uncommon but well recognised complication of untreated hypertension, and that is of malignant hypertension with multi-organ end organ failure. Now, the current advice from some authorities is to not commence therapy for hypertension without first assessing absolute risk. The other thing to note about this chap is that he'd been under the care of a specialist unit at a tertiary medical centre for some time for an unrelated condition. Now, if you put his parameters, say, a few years prior to this event into a risk calculator, say at the age of 40, with a systolic blood pressure of 158, the risk calculation would come out at 2% or low risk, and so perhaps would be a disincentive to treatment. So the point about this, it's really important to think about both blood pressure and risk, and think about them together and not regard them as being dichotomous issues. So what to say about drug treatments for hypertension? I thought I'd talk briefly about what's used in Australia, and also to talk a little bit about dose-response relationships and the single product combinations available in Australia, particularly in this relation to this question of initiating with combination therapy. So this is from a table of the top prescribed drugs by the PBS, and what you can see is that for 11 out of the top 50 drugs were antihypertensives, mostly ACE inhibitors or ARBs or calcium channel blockers. There's relatively little use of diuretics in this top 50 drugs, and limited use of combination medications. Just as an aside, if people are using or have patients on combination medications and they want to know the individual agents that are in them, there is a useful table in the Australian Medicines Handbook that you can look up to help you understand if you're wanting to switch or change therapy. Now, for most drugs, there's a relationship between the dose and the response, so that as the dose increases, so does the effect of the drug. For many antihypertensive medications, within the products available, they're often at the top of this flat end of this dose response curve. So increasing the dose may not increase the blood pressure effect that much. Starting doses might be lower than the maximum dose, and so here you would be looking to get some effect but perhaps have less chance of getting adverse effects. Now, if you're wanting to use a combination medication to start, so that's 2 antihypertensive drugs together, ideally you'd be wanting to have a low dose that is below the recommended starting dose of any individual agent, as the two together might work synergistically. Now, if we look at the fixed dose combination tablets that are available in Australia on this left-hand column here, this is combination tablets, and I've put the dose of each particular agent, or the lowest dose of each particular agent. And if you compare the dose in the combination product with the recommended initial dose for that as a single agent, you see here for amlodipine, the dose that's in a combination product is substantially higher, around 200% of the recommended initial dose. So these combination amlodipine products available in Australia are not really suitable for initiation of therapy, and that is the case for the majority of agents available here. There was some work done using the 10% PBS prescribing sample, looking at initiation of antihypertensive therapy in Australia and persistence with therapy and uptake of fixed dose combinations. This was using the 10% PBS prescribing sample. And what they found was that the dark blue line here at the top, if initiating with monotherapy, people were more likely to persist with treatment than if initiating with a fixed dose combination, where they were more likely to discontinue all blood pressure lowering therapy in the first year. And I think this, I mean, I was aware of this data, but I hadn't looked specifically at the combination products we had available. And I think having looked at what we've got and the doses, this makes sense to me. And I think the products that we have are more designed for add-on therapy or rationalisation of therapy rather than initiation of therapy. Now, one thing also that it's worth thinking about in terms of use of medications is idiosyncratic drug reactions. And these are not common, but they can be problematic. So the question here for people is which one of these pandas is different and at risk of an adverse drug reaction, because we can't necessarily predict it for patients. So there it is, the bottom left of the screen. Now, I've just listed a couple of more serious adverse drug reactions. So that is of ACE inhibitor angioedema and olmesartan villus atrophy. The interesting thing about both these adverse effects is that they both emerged in the decade after registration of these drugs. So ACE inhibitor angioedema in the mid-90s after these drugs entered practice in the 1980s, and olmesartan villus atrophy in 2012 when the drug was registered in 10 years earlier. And this X-ray here, this is a lateral X-ray of a head, and what it shows is that the oral cavity here is filled with this soft tissue opacity, which is the tongue, which has been swollen with this ACE inhibitor angioedema, risking airways obstruction. So it can be a concerning adverse effect. So just in terms of exposures of populations to drugs, it is important to think about the potential contribution to uncommon and rare adverse effects. So just to summarise, there is a very large amount of data and information and knowledge about blood pressure and hypertension and its relationship to risk and disease states. Where there are differences or conflicts in guideline recommendations, that can be for a number of reasons, such as differences in prioritisation of the evidence, geographic differences, technologies available, or practice issues of the way practice is structured, or even philosophical reasons, such as the differences in approach to risk. And measurement remains an enormous issue. But I think the main point is that if you have an understanding of the evidence and how it's been interpreted, and an understanding of the differences between guidelines, there are really many more confluences rather than conflicts. And that treatment of hypertension remains an important challenge, and it's worthwhile of a focused collective effort, as the guidelines are an example of, as treatment can be very effective and very rewarding. Thank you.